Welcome to the Advanced Women's Health Podcast, where we empower women with the latest insights and advice on holistic health. From cutting-edge medical research to practical wellness tips, our mission is to help you thrive at every stage of life. Join us as we explore topics ranging from hormonal balance and reproductive health to nutrition and mental well-being. Whether you're seeking solutions for a specific health concern or simply want to enhance your overall wellness, you're in the right place. Let's embark on this journey to better health together. This is the Advanced Women's Health Podcast. Hello, and welcome back to the Advanced Women's Health Podcast, where we are starting our fertility series for the summer. So what we're going to be doing in this series is I am going to be walking you through some of the big things that I think are not talked about with respect to fertility. And obviously, whether you're trying to get pregnant or not, I always say healthy body makes a healthy baby. And so there's so much to be learned here preconception. There's so much to be learned here about hormonal health in general, immune health, how hormones and the immune system interact. So there's definitely something here for everyone. So essentially what we're going to be doing is breaking down fertility into four really large kind of swaths or sections. One is, are you ovulating? Because there's this assumption within society that if we are having a period, then we're ovulating, and that is not the case. So we will talk about that. And we're also going to talk about some more kind of advanced topics, things that we see changing and evolving at Advanced Women's Health, just because we see such a large volume of people. So we're going to talk about that. Then we're going to move forward. We're going to talk about the circulation. We're going to talk about structural environments. We're going to talk about sperm, and we're going to talk about essentially that kind of structural sperm and egg meeting, endometrial receptivity, and so much more. So this is going to be your big masterclass diving into all things fertility. As a reminder, we do have a fertility fellowship at Advanced Women's Health, so our docs do get advanced training. If you're interested in working with a doc who has advanced training, then you can always reach out to our team and we will ensure that you get the best person. I have a clinical assistant that I work with to oversee care. We have Dr. Lauren, who leads our fellowship, and then, like I said, a variety of other practitioners as well who are just really enveloped in this area and really passionate about it. So let's dive in. Before we dive into today's episode, I wanted to let you know about some exciting things we have been working on at Advanced Women's Health. So we don't aim to just be excellent at appointments and excellent with the care we give to patients in terms of the protocol, but our goal is cross-clinic excellence. We want to ensure that you are getting the most wonderful onboarding experience, that you feel supported, and that fundamentally you actually are going to implement your plan. We talk about health being a lifestyle, and it is, right? It is something that needs to be modified or shifted. We need to think about things differently. We need to understand our bodies differently. We need to have those education-based aha moments or those community-based aha moments to be able to action what we know to be true and what we know we need to do. And so over the last few years, we have been consistently evolving and trying to give you the best patient care experience possible. And that has resulted in us having our new patient onboarding system. All new patients at Advanced Women's Health now get access to a plethora of resources. We go through educational pipelines and daily tips and tricks that will help you to implement your plan. We have mindset support. We have onboarding coordinators that are there to create community and hold your hand in live QA calls. We offer meal templates and meal plan structures, exercise videos and programs, community challenges, and so much more. And again, this is just included as being part of a patient of Advanced Women's Health. So if you have been on the fence, if you have been hesitating, book with one of our patient onboarding coordinators. We are here to help you pick which practitioner is the best fit for you. And then you can learn more about our onboarding systems and everything else we offer at Advanced Women's Health. So now to the episode. Today, we are going to talk about ovulation. And how ovulation is about so much more than having a period. And this is something that I think the birth control process has really confused, because when we look, someone takes the oral birth control pill, right, to suppress ovulation. When someone is on an IUD, whether that is hormonal or copper, that doesn't always suppress ovulation. So that's just something that's important to keep in mind, that if you are on one of those devices, again, I don't have time to dive into the ins and outs of those devices and the risks and benefits and everything there, because that's a whole many podcasts in of itself. But you sometimes ovulate, sometimes don't. So when you're off any form of birth control, right, there's this assumption that a bleed is a natural bleed. And when you're on some kind of birth control, it's a withdrawal bleed or spotting in the case of an IUD, or an actual period in the case of an IUD. If you're bleeding, it's just oftentimes in those situations, we have a thinner lining. We have a change to the nature of the lining. But alas, we assume we are having a bleed, and therefore that means we are ovulating. And that is something that we are seeing time and time again is not necessarily true. So we use a company called Mira quite often. It's a company that I actually help do some scientific research and back end and consulting for, just because I find it such a wildly helpful tool. But when we look at Mira, it's a urinary at-home hormone test. You can also do the same thing in blood if you wanted to go to the lab every few days. But we're looking at how your brain is talking to your ovaries and then how your ovaries are responding. And so when we see the brain talking to the ovaries, we're typically looking at two big things. So we're looking at follicle stimulating hormone, or FSH, and we're looking at luteinizing hormone, or LH. We have many podcast episodes where we talk about the dance between these things, but essentially what we want to see: brain stimulates a follicle with FSH. That follicle starts to develop estrogen. We should have enough estrogen that triggers our brain to say, woo, ovulation, right? In that term, actually, woo is key to that whole process. But then we have ovulation occur. That egg should rupture out of that follicle, right? Should go into the fallopian tubes. And the cool thing, which we'll talk about with structure, is that when we see ovulation occur, so let's say ovulation occurs from right here, okay? That's where the egg comes out. If the fallopian tube is here, and that fallopian tube is the connection to your uterus. So if it's in a different spot and that's the connection to your uterus, then obviously that egg is not going into the uterus. So the fallopian tube has to be able to move, and we see it like crawl around to surround the area where ovulation is going to occur, which is crazy cool. But also requires the mobility and motility of the fallopian tube. It needs to be able to move. So if you have endometriosis or pelvic scarring or adhesions, you have a history of pelvic inflammatory conditions, then sometimes that movement doesn't occur. So that's one of the big factors, can we catch? Is there a catcher there? And so when we look ovulations occurred, then we should make our progesterone, a little bit of estrogen that should carry a fertilized egg to be able to implant, allow the immune system to shift such that implantation occurs, and then boom, it grows, develops, and off to the races we go. So that's the theory, right? This is the theory behind we move through things, but obviously there's individual situations. So if we see that the brain is talking to the ovaries and the ovaries aren't responding, or we see that someone doesn't have a luteinizing hormone spike to estrogen, and then subsequently we also don't see progesterone, then those are two signs that you are not ovulating. And so obviously testing hormones is key to that. This morning even, and honestly every day on our clinical rounds, someone generally has some type of weird hormonal case or something going on. So this morning we were talking about someone who was trying to conceive. And so we started doing what they call cycle monitoring. So monitoring what's happening between the brain and the ovaries, how the ovaries are responding throughout the course of the month. And there was just no ovulation, even though this person was having a bleed every 30 to 40 days, which is a bit long. That bleed was not a period from ovulation, meaning you didn't ovulate, thicken the lining of the uterus, and then start to break that down and have a bleed when there was no embryo to implant. And that communication And the breakdown in communication, the inability to ovulate has a lot more consequences than just fertility. We know that estrogen and progesterone are very important for the immune system. We'll talk about that as we go. We also know they're very important for brain health. We are on this huge perimenopause movement right now where everyone's talking about hormones. But if you're in your 20s, if you're in your 30s, it doesn't matter your age. If you're not ovulating, then you don't have that progesterone to calm the system down, to calm the brain down, to relax the body, to reduce inflammation, to allow a deep sleep. If we don't have enough estrogen at the right times, then cognitively, our brain doesn't respond as well as it could. Our brain doesn't use the fuel that we want it to, it doesn't use glucose as well. We know that we're not going to get the same muscle development. We're not going to get the same of a lot of things, right? We have metabolic changes. All of these things start to happen. And so we need to understand that ovulation is an indicator to health because fundamentally ovulation is important, but not ovulating is also a big question mark. We have to ask, why is the body not ovulating? Yes, I could put you on birth control and then you would get some protective hormones potentially, especially when it comes to like the synthetic estradiols. That can be very important for bone health, brain health. Depending on where you are in your life, you may be put on bioidentical hormones like estrogen, progesterone can be very, very important. The question is why? So if you have a inflammatory event in your pelvis that has damaged your ovaries, whether that is a viral infection, whether that is a bacterial infection, whether that is any type of infections, STIs, etc., that damage to the ovaries, if it damaged the ovaries that much they can't ovulate, then where else did it damage? What else is happening in the system that we can't see? It's a really, really important question. If you have an autoimmune condition that's attacking your ovaries, an autoimmune condition is essentially when we have our immune system confuse our own cells and our own kind of body type, right, as a foreign pathogen, as a bacteria or a virus. So it fights our ovaries in this situation. There's something called anti-ovarian antibodies. We don't test them at like a Life Labs location. They're only tested in the research right now. But anti-ovarian antibodies essentially says we have an immune process that is telling us that our ovaries need to be attacked. They're a bacteria or a virus. Well, if your body is attacking your ovaries, what makes us think it's not going to attack your thyroid or attack your knees or attack something else? So again, this is a big sign that there is some kind of other process that we need to better understand. If you're not ovulating because you have PMOS or polycystic ovarian syndrome, then that's telling us that we have a metabolic picture. So there is some kind of insulin signaling issue that is contributing to static in the signals. We're not getting the right signal to our brain, to our ovaries. And the process, so FSH and LH are what we call gonadotrophin hormones. So GnRH is gonadotrophin releasing hormone, is essentially the pulsatility. It's the action of those hormones from our brain to our ovaries and how fast they go. And we know in polycystic ovarian syndrome, there is an abnormal communication. Most of the time, it's really fast, right? So we're not getting that proper signal down to our ovaries. Whereas another reason we can't ovulate, something like, which is the opposite end of the spectrum, something like what we call hypothalamic amenorrhea, means that our brain, whether due to low body weight, whether that is due to some kind of major stressor, whether that is just, even if your BMI is normal, but undernutrition, right? All of these different things tell our brain, maybe not safe to make a baby, right? And that's, to your brain, the only purpose to ovulate. So when we look in the hypothalamic amenorrhea, it's very slow pulsing, right? Because that communication just turns all the way down. And so these are the things we can pick up in blood work for sure. But these are also the kind of diagnostics that we're going through. We're saying, okay, are you ovulating? So when we're testing blood work, so let's just kind of fast forward a little bit. So let's say you have been trying and you go to a fertility clinic. A fertility clinic is going to, as a general rule, not all fertility clinics are the same, everyone. But alas, we are not going to go there today. Um, they are generally going to do something called cycle monitoring. So essentially, they'll say, call us when you get day one of your period. So you get your period and then you go in and they take your blood. They're testing your FSH and your LH, communication between your brain and your ovaries. They're going to test estradiol. So they're saying, okay, how are those ovaries responding? Right. And then they'll test other things as well. We'll get to anti-Müllerian hormone or AMH. They'll also test thyroid function. So they'll test TSH. They'll do basic blood panels. Oftentimes they're doing some immune work as well. So just seeing, do you have reactivity or do you have antibodies to important vaccines for pregnancy or like hepatitis or even viruses? Have you had a virus recently that would impact your chances of pregnancy? So depending on the clinic, they'll do different testing like that. Sometimes it's very minimal. It's just hormones, check your blood cell count, check. Sometimes they don't even do TSH. But then they're also going to be testing and they're going to be doing a transvaginal ultrasound. And so that's checking the thickness of your lining for fibroids. That's checking for adenomyosis, endometriosis, any cysts on the ovaries. And then they're also going to be looking and doing something called an AFC or an antral follicle count, which we're going to get into as we go. Then they're going to be watching and seeing how many of those follicles are marching forward. Is your brain and your ovaries talking? Is that communication fluid? Are your ovaries responding? We're just essentially trying to create what we call a closed loop. So brain to ovary, ovary to brain. And we're just testing in the bloodstream every couple days and then doing that ultrasound as well to monitor and see how many of those eggs are marching forward. But that is what we have the potential to do with a fertility clinic. If we are going to do this blood work at a Life Labs or a Dynacare location, then oftentimes your clinician will tell you to go between cycle day 2 and cycle day 4. And cycle day 1 is the first day of bleeding. And so what we're looking at is communication between brain and ovaries. We're looking at estradiol and then any other hormones we're running as well. So if we think you have PMOS or PCOS, then of course we're running testosterone, DHEA, that kind of stuff. We don't test progesterone on this day because progesterone only comes in the second half of our cycle. So we're just doing some initial testing to see what is happening between that communication. But as clinicians like myself, I don't send someone to the lab every 2 or 3 days. So that's where urinary hormone testing comes in handy because we can actually see what's happening between that brain ovary communication. And then we can also see what's happening with how much estradiol or E3G is being released. And then also what's going on with progesterone and PDG. So we see, oh, look, it's starting to come up in the second half of your cycle after you've had a peak rise of luteinizing hormone. Therefore, yay, you've ovulated, but we can see that come throughout. So when we look at the brain communication with the ovary, those are a lot of the really important pieces that we're looking at. So let's just dive in here into a little bit more detail because I think it's really important. So this picture here, I really like. It's from a Nature article called Anti-Müllerian Hormone and Ovarian Reserve Marker in Primary Ovarian Insufficiency. So let's break down a couple things here. I just wanted to give proper credit where credit is due. This picture is from this article. So when we're looking here, we've got our hypothalamus in our brain, okay? And then we have our pituitary gland that's making FSH and LH. And then it's also responding to estradiol and inhibin B. So this is why we don't test inhibin B in the research, but this is why we're looking at this as a closed circle, okay? So we've got that GnRH, as I was saying, so gonadotrophin releasing hormone coming from the hypothalamus goes to the pituitary, and then boom, we have this communication. So when we're looking, there's a couple things that have changed in the recent past. And the reason I brought up an article about premature ovarian insufficiency is essentially this is a condition where before 40 years old, you have a very high level of FSH, follicle stimulating hormone, over 20 to 25 consistently. Most of the time, historically, this condition resulted in you having very irregular periods around that period of time. So honestly, years and years ago, when I first started practice, so 10 years ago at this point, when I looked and when I got someone who had a diagnosis of premature ovarian insufficiency, they came in either for fertility, so they were not able to get pregnant and they came in and we did testing, or they went to see their fertility clinic and then they got sent to me to help to support, or they were in a situation where they were having these irregular cycles before the age of 40. And so we did the diagnostic and we could see that happening. Things have changed a little bit in the recent years. And I think research is going to take a really long time to catch up. And so I'm going to talk about what we're seeing because I think it's very important to understand how things have changed. But historically, we were looking for concordance between three things. Okay. So meaning three markers told us the exact same story. So FSH, follicle stimulating hormone, was high, meaning the brain, right? The pituitary is screaming at the ovaries, like, make an egg, make an egg, make an egg. And there wasn't an egg. There's nothing to develop. So the second marker we're looking at is AMH, so anti-Müllerian hormone. On here, if you're looking at this image, there are three little types of follicles. So we have a primary follicle, a pre-antral follicle, and then we have a small antral follicle. All of these follicles are making anti-Müllerian hormone. So we use anti-Müllerian hormone as a marker of reserve, the amount of eggs we have in reserve. Because when we're looking here, what is happening? This is one egg. So this is going from a primordial follicle, which we'll talk about here in a second, all the way through to a antral follicle, then ovulation, then corpus luteum, then it generates, right? We go into what we call atresia, and then the cycle is continuing every month. But what we don't show pictures on here of is that the fact that there is a whole bunch of these antral follicles that are developing at once. So we don't develop one egg, right? One primary follicle doesn't then move forward and it's ovulated. That's not how this works. And so we have a whole bunch of follicles that are marching together, okay? And then one of them or two of them, depending on the person, the month, starts to become the dominant follicle. And it's like, nope, I'm controlling this environment. And then we start to see the other follicles break down, go away, go into atresia. That's why we say we lose lots and lots of eggs every single month. It's not like you lose one egg every month. And so when we're looking, the next marker, so first we have FSH. So how's our brain communicating to our ovaries? Then we have our AMH. So how many eggs in theory are in reserve, and we're going to expand on that. And then we look at antral follicle count. How many of these antral follicles, this is the antrum, this purple area, right? So how many of these antral follicles are developing every month? And there's normal levels of FSH for your age. There's normal levels of AMH for your age. And there's normal levels of antral follicles or antral follicle count for your age. So essentially what happens is your FSH, when you're younger, we assume it should be lower, right? So anywhere between 5 and 7 for the most part, because your brain is like, hey, make an egg. And then your ovaries are like, yeah, how many, right? So it's a very smooth, fluid communication process. But then as we get older, we also expect to see our AMH at its highest point. There's a couple different units for AMH for age. So I'll park that in the blog post that goes along with this, and then you'll be able to better understand where you fit if you've tested your AMH. And then there's antral follicle count. So antral follicle count, for the most part, when you're younger, it's upwards of 16. And then as you get older, it can be as low as like 4 to 8. And so all those three things should tell the same story. So if we see AMH is low, we expect to see that FSH is a bit high. And then we also expect to see that your antral follicle count would be low. So like 4, 6 type thing. What we are seeing right now, which is a new change that I am not going to hypothesize about why I think it has happened on here, but we are seeing a shift in the last few years in the types of fertility cases that are coming in. So one of the patterns that we are seeing is people have FSH that goes up and down. So 1 month you could have a perfectly normal cycle, and the next month your FSH could be really high. Okay. These people will oftentimes also have a low AMH for their age category, not non-existent, but low. But they also can have a reasonably normal antral follicle count, or AFC. This is like the stickiest part of this podcast for anyone listening who's not like a fertility person. For people who are at fertility clinics, they're like, woo, I'm with you. You know what I mean? Like I'm following. But for people who are not, I promise we'll get back to the conclusions here. But this is a really important concept to understand if you are someone who has a moderately low AMH, or if you are someone who is supporting someone who has that, please share this with them, or just in general, if you're very interested. So, what I think is happening in those situations is on this image, you can see there's blood flow, right? And that blood flow is really critically important for these primordial follicle pools. And these primordial follicles do not contribute to the AMH. So these are follicles that are sitting there, they're available, but they're in arrest, meaning they're not developing and moving forward. And so in that case, we do have patients who have a lot of ovarian inflammation. They've had a history of viruses or bacteria or infections. There's fibrosis on their ovaries. They have endometriosis. There's inflammatory processes that are happening. Things are just not working properly. And so they have this pool available, but it's stuck in arrest. We see this happen after surgeries, for example. There's a lot of research to suggest that if someone is having endometriosis surgery, there's a sweet spot because there's a period of time after your surgery that your ovaries are like, woo, they're shocked, right? They're inflamed, damaged, shocked. And then in those situations, we see that AMH can drop. So anti-Müllerian hormone can drop. So that tells us that the ovaries are in this kind of danger response. And so everything is shut down. And then 6 months later, oftentimes that anti-Müllerian hormone can drift back up and that person can start to ovulate normally. That's something that we see happen. We see this happen when people have their tubes tied or removed as well, right? Any kind of surgery, any kind of inflammation can definitely contribute to the ovaries being in this shock stress state, not ovulating. Some people immediately go into a perimenopausal state, and then 12 months later, they drift back, right? They'll start to ovulate normally again. So these are all things that we see well documented in case studies in the research. So if you have an antral follicle count that's normal, and 1 month your brain talks to your ovaries fine, and the next month it doesn't, then my question is always, why could your ovary be inflamed and damaged and stressed? Because why are we not taking these follicles that are sitting there that should be marching forward? Why are we not developing these follicles? Why are we not having an AMH that is consistent? So that is one of our first signs as clinicians in advanced women's health that we are really looking for some sort of inflammation, some sort of, even historically, we've seen like blood flow issues like microclots is something that can affect the ovaries in a really significant way. There's so many different patterns that can come up. But in any situation, this is a really important pattern to detect because there's a lot of fertility clinics we work with that they get this. They're like, oh, this makes sense. This person, as much as it may not be easy, still has the potential to get pregnant because they don't have a consistently high FSH. Like they still have antral follicles or these developing eggs that are going towards ovulation. This person can still get pregnant. And they have enough eggs around that if we can get them to ovulate, we can reduce the inflammation, we can support the blood flow, we can support the lining of your uterus. Like we have a decent chance here. Whereas some other fertility clinics will see that FSH as soon as it's high once and the AMH is low, even if the AFC is 6, 7, 8. They're like, no, we're not doing this. So working with a team that understands the depths of this conversation is really important, which is why I'm putting it out, even though, again, this is likely far and above beyond what some of you listening to this podcast are interested in. But for those of you who have a low AMH, who are really fearful about what that means, this is the type of conversation that you should be able to have with your healthcare provider. You should be able to look at, is my FSH consistently high? Is my AMH low? And is my AFC low? If you are 30 years old with a consistently high FSH over 20, a consistently low AMH and antral follicle count, then we need to have a conversation about, are you ovulating? You still may be, right? AMH doesn't tell us, and this is why we say this all the time, AMH doesn't tell you about your chances of getting pregnant every month. AMH tells you about how many primordial follicles are in reserve. So it gives us an estimation of how long your reproductive years are. That's it. That's all. And so you need to work with someone who understands the depths of that, but who also understands how to tell if you are ovulating. And if you do not and are not making enough hormones consistently, then as I said, your brain health, your bone health, your immune health, your nervous system, all of those types of things are at risk. You need to be working with someone who understands how to optimize premature ovarian insufficiency hormone replacement, because this is very different than like hormone replacement in menopause, because you need those hormones. The risks of you having osteoporosis and neurocognitive disorders, right? Metabolic dysfunction, immune dysfunction is much higher if you go through this process in your 20s and 30s and you don't get add back hormones. So it must be considered. But in any situation, if you're getting any kind of discrepancies or any kind of abnormal results and you're not getting information described to you with this level of detail, I highly, highly recommend you seek another opinion, because this is not me discussing naturopathic medicine versus conventional medicine or the importance of a fertility clinic or the importance of natural psych. I'm not talking about that. I don't care what you do. I just need you to work with a provider who understands that the fertility world has changed in the last 10 years. And if you are not working with a team that understands those patterns and has watched these changes unfold, like historically, the only cause of premature ovarian insufficiency or premature menopause is another way to put it, right? The only cause I saw in my practice was medication induced or from someone who has Hashimoto's thyroiditis. So an autoimmune attack on your ovaries, because there is what we call a cross-reactivity. So your ovaries and your thyroid look a little bit similar to your immune system, which is very interesting to me, but they do apparently. And so with that, we saw that there was a higher likelihood of premature ovarian insufficiency. So if you had Hashimoto's or hypothyroidism, didn't mean you were going to have premature ovarian insufficiency. But if you did have premature ovarian insufficiency, your chances of having thyroid antibodies was very, 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 very high. So that historically was the cause, the reason. That's how we treated it. Even fertility clinics historically, as soon as they saw one FSH that was sitting at like 15, they're like, nope, not a candidate. That has developed and changed a lot, because so much of this has to do with the immune system, viruses, circulation, inflammation, and so much more. So I just really want you to know that. And again, you might need to listen to this podcast 5 times. That's okay. You may need to take notes on it, right? And then bring those notes into one of our doctors and be like, explain this to me. But this conversation and the feedback loops here are really important. And so one thing that you will frequently hear is when we're looking at estradiol levels. So here it feeds back to the brain. So it's telling the brain either to trigger luteinizing hormone, which happens, right? Or it's telling the brain, okay, we don't need to make as much FSH. We don't need follicles. Our follicles are developing. So when we see these LH and FSH bounce up and down, we need to understand if estradiol is high or not. So in Canadian units, if your estradiol is over kind of 220, 250, it can start to decrease the communication between your brain and your ovaries. So sometimes we'll see people come in and they will have an FSH of 6, which looks pretty normal. Their luteinizing hormone looks weird and their AMH is a little bit low, but no one ever tested their estradiol. And then when we test their estradiol on cycle day 3, it's 500. Well, that's telling us that there's a whole bunch of these follicles racing forward and they're all making estrogen. These are not healthy ovulatory follicles. These are follicles that responded to the brain saying, go, 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 make an egg. And you made as many as you could, not healthy ones, just as many as physically possible. And then they all started making estrogen. And then the estrogen came up and screamed at the brain like, halt, we have too many eggs growing here. And then they all went into atresia, okay, or breakdown. So that happens in late stages of perimenopause. This is why we can get huge swings of estrogen. But if you are being investigated for fertility, then you need to make sure that this loop is closed. We have FSH and LH on cycle day 3. We have estradiol on cycle day 3. We have AMH on cycle day 3 is easy. And then we also, then in that situation, can understand the antral follicle count. Some very advanced fertility clinics are also looking at this circulation. So they're looking at how well are the ovaries getting oxygen, right? Getting blood flow, getting nutrients. And so there's a direct connection between quality of eggs and egg quality and that. If you're like many of our patients that are struggling with your health, then you have looked into one of many, many, many programs online. There are programs with doctors, with naturopathic doctors, with functional medicine practitioners, with nutritionists, with people who have been through what you are experiencing. There are so many options available online. But the reality is, a lot of these programs are not medically guided. When you sign up, they say right away, this is not personalized to you. This is not personalized to your labs. I can't diagnose you, which is a huge limitation. They're also very costly. Many of these programs are $2,000, $3,000, $5,000 for a 3-month program. And that leads to you, one, not getting the best standard of personalized care, and two, spending money that you may not have to. And that's where our clinically guided programming has come in place. I have wanted forever to be able to give people an educational system, a week by week guide, an exact system so that you know what you're expected to do, what you're expected to eat, and how you're expected to navigate week over week over week over week. And I have been working with my team, my clinical teams, my clinical assistants to be able to roll out structured programs for you that are in the hundreds, not thousands of dollars. We are so excited to launch our advanced metabolic rehab, our fertility programming, and so much more upcoming. If you are interested in learning more about our structured and clinically guided programs, make sure you reach out to the clinics, info@advancedwomenshealth.ca. They will connect you with one of our clinical assistants and guide you through what programming might be best for you. The best thing is that these are in and above your appointment. So you are having your naturopathic visits, your acupuncture visits, and then we are layering on top a supported experience that allows you to utilize extended benefits should you have them, but that also allows you to get, again, a highly tailored medical environment. So reach out to us if you have more questions. And now back to the episode. So I hope that helps. I hope that you can get some sense of a picture of what is going on with the cycle of ovulation. So we've talked about AMH, we've talked about ovarian reserve, which is those primordial follicle pools. Okay. We've talked about antral follicle count. We've talked about how those follicles are recruited. So your brain is talking and then they all start marching forward. And then if they have enough blood flow and enough nutrients and a healthy amount of something called a mitochondria, so the energy powerhouse of the cell, it is our battery, but it is also the thing that makes our hormones, then we can then make enough estrogen that triggers our brain to cause ovulation. That ovulation process occurs. Then we have progesterone that is made. And so that progesterone is made from something called the corpus luteum. Also requires a healthy mitochondria or battery pack, right? This is why we talk about CoQ10 and carnitine and NAD and a lot of these nutrients. And we need to then, in that whole process, ensure that the tissue is healthy, it's getting enough blood flow, we do not have nutrient deficiencies, and we do not have something called oxidative stress or cellular resting. So when there is, after an injury or inflammation, we know that there is more amounts of fibrosis or scarring. Like if you just picture a scar, right? We don't want that on our ovaries. But in the case of high glucose levels, in the case of persistently high inflammation, in the case of environmental toxins, so there's a variety of environmental toxins that are established to be of concern. In the case of normal aging, or again, accelerated aging due to a history of any of these things, smoking, alcohol use, all of these things contribute to something called oxidative stress or cellular resting. So as you can imagine, if we have rusty ovaries, they're not making the hormones we want. They're not responding to the signals from the brain properly. And then we see a decreased quality of our eggs. So this is where we talk about egg quality, right? So what that is, how healthy is that egg, right? How likely is it to respond? Is the outside of that egg hospitable? Meaning, can a sperm actually get in there? Right? There's a whole process of the immune system's responding, cell signaling. It's a crazy process. If you ever get a chance, it sounds so nerdy, but like to go on YouTube and watch a sperm enter an egg, it's like I would honestly get nothing done. If I worked in a fertility clinic, I'd be like just watching all day. Like, go, buddy, go, get in there. Anyways, that's it's a whole other conversation. But when we're looking at that, if we have all of those things in place, right? And we're going to talk about this in sperm health. If we have healthy DNA of that sperm, healthy DNA of that egg, which plays into oxidative stress, healthy hormones, then fertilization can occur. If we have damage to the ovaries, again, whether that's virus, bacteria, infection, environmental toxins, smoking, drinking, insulin, all these things, stress, right? Hormones. Anything that happens there, all of those things are going to reduce someone's egg quality. And I'm obviously oversimplifying that, and impact the ability and the chances of fertilization occurring. So let's say even if that egg beats the odds, ruptures out, the fallopian tube finds it, goes down the fallopian tubes, meets a super healthy sperm, there is still going to be that piece in place where we're looking at the quality of that egg to see if it's likely to fertilize and then likely to result in a true pregnancy where an embryo slash fetus is going to continue to develop. So these are all the different things that we think about. Each one of them is its own individual thing. Two other factors that I think are important to talk about when we're talking about ovulations. We've talked about insulin. We have talked again about the brain talking to the ovaries. We've talked about the energy powerhouse of the cell, making our estrogen and progesterone. We've talked about nutrients. Those are very important in this process. It's a very energy intensive process, right? We also need to talk about really two other factors that we hear about a lot. One is thyroid function, and two is when we're looking at stress and ovulation. So thyroid function is simple to explain in two main categories. One is, as I mentioned earlier, if you have premature ovarian insufficiency or some kind of dysfunction, then what we see happen is there can be a connection between the antibodies and the ovaries. So thyroid antibodies and the ovaries. If you have an autoimmune attack on your thyroid, that's one, highly inflammatory event. And two, that is something that is going to decrease the amount of thyroid hormone available. We need a lot of thyroid hormone or energy to ovulate and to make healthy eggs. So even if you're one of the small percentage of people, probably 30% or so, that do not have an autoimmune attack. So what I'm saying is anywhere between 70 and I think the research shows like 60 to 80% of people who have hypothyroidism, so poor thyroid function, low thyroid function, right? It's very confusing. Your TSH is high because your brain is screaming at your ovaries, no, it's screaming at your thyroid. It's not screaming at your ovaries, but the brain does a lot of screaming. It gets very screamy when it's not in a good place because the brain likes consistency. But if we don't have enough thyroid hormone, TSH goes up. That's called hypothyroidism. The large majority of those people have an autoimmune attack damaging their thyroid gland, which is a butterfly-shaped gland in the front of your neck. If that autoimmune attack is there, then you're not consistently getting the hormones oftentimes that you need. And you're also having that inflammation in the body and potentially inflammation in the ovaries. If you have hypothyroidism that's not autoimmune, you still aren't making enough hormone. It's just there's not enough gas in the gas tank. And so we oftentimes will not ovulate in those situations because, again, the body is like, okay, well, if you don't even have enough energy to ovulate, how are you going to grow a baby? So thyroid function is important for many different reasons. Then we get into the conversation about stress. So we've all heard it. If you've said it, forgive yourself, learn your lesson, and move on. Just go on vacation and have sex and you'll get pregnant. It's not a conversation I love, not a conversation I think should happen. I really don't think anyone, to be honest, should be advising someone, unless they're a doctor, on tips and strategies to get pregnant, unless they're being asked. If someone asks you, right? If they're like, what do you think I should do? They open that door. That's fine. But unsolicited advice is what we call it to people trying to conceive is generally unhelpful. Even as a practitioner, unless someone asks me my opinion, my mouth is shut, right? Even if I'm standing there, we always joke, like at the barbecue, I'm hearing everyone's stories. I'm like, don't say anything, right? But unless I'm asked, I don't speak. And I think that is the best practices. But one of the big things we hear is just relax and have sex, and then you'll get pregnant. And the annoying thing is sometimes that happens. And then people are like, oh, well, stress must be the thing for everyone. Let's talk about stress. Okay. First and foremost, fertility is a very stressful situation. For a lot of our patients, they love control, right? They can control everything. They control their dog, their partner, they control their food intake, they control their environment, they control, but they can't control if they ovulate, if an egg and sperm meet, and if that then proceeds to implant and grow. It's a lack of control environment is a very stressful thing for people. So fertility in of itself is stressful. Then we add jobs, life, expensive treatments, having to get to labs, all these types. Even if you're just having sex for the first time, you pull the goalie, you know what I mean? You're like, it's still a panic thing because now you're like, I can't control this. I can't control if I get pregnant. If I get pregnant, how am I going to feel? And then my whole life is going to change. How's this going to work? Again, we hear it every day, all day, to be honest. It's all good. We've heard everything, but it's stressful. And so there's two stress responses, our fight or flight response, which is epinephrine and norepinephrine. And then we have cortisol. Okay. And they both have detrimental impacts on fertility. I get it. Yes, they do. But we can't sit here and say we have stressed ourselves into infertility because the reality is there are people more stressed than you. There are people in war-torn countries who are starving who get pregnant. So it's not just about stress ever, but there are two things that are really important to consider. With the fight or flight response, not only does it keep you awake and alert and really like, again, that anxiety type response, it also shifts blood flow and it changes how we use our nutrients. It also changes our metabolism in many ways. Okay. Then when we look at cortisol's doing many of those things, changing blood flow, we know that in the face of chronic stress, some people do gain weight. So it can change the insulin and the hormone signaling that way. Both of those responses are changing circulation, the very important blood flow to your ovaries. We also see that it's changing the way your brain talks to your ovaries. So in cases of really high stress, we can lose our period because our brain is like, do not proceed. This is not the month to make a baby, right? So even if you do bleed, you might get a long cycle. Your ovulation might be delayed a few days. We do know that chronic stress can affect the mitochondria and reduce the amount of hormones that we can make. So all of these things happen, and cortisol is very involved in the immune process. This is why when we're very, very stressed, some people can get a cold sore outbreak. They can get shingles. In certain situations, people will go through very stressful periods of time and then they relax and they get sick, right? You hear that with kids all the time. They come out of exams and then they get sick on their holiday break. You go on vacation, you get sick. That's oftentimes because we are seeing a shift in how cortisol is affecting the immune system and inflammation. And so cortisol in the right amount, in a healthy dose, is a very important anti-inflammatory. So if you're not making enough cortisol, which is happening a lot with our patients these days, then you don't have that anti-inflammatory, that turn off the inflammation signal. And if you're in a situation where you have lots of cortisol, then you can actually suppress your immune function. So there is a relationship between ovulation and whether your brain is told to make an egg and the quality of that egg and the blood flow and all of these things. But I do think that sometimes we overstate or talk about the value of stress in a way that causes more stress. And then we get very meta because we're stressed about our stress, right? So we don't want to do that. So as we wrap up this episode, we've talked about a few different things, but fundamentally, it is very important that you are testing your luteinizing hormone and your follicle stimulating hormone on cycle day 3. You are testing your estradiol on cycle day 3, and you're looking at your anti-Müllerian hormone. If you are believed to have PMOS or PCOS, then we should be looking at your testosterone and your DHEA. We also know that prolactin is a hormone that's made as well that can inhibit ovulation if it's very high. Prolactin's high when we are breastfeeding and a bunch of other environments, but some people have a dysfunction where they have high levels of prolactin, and that inhibits them from ovulating. So we should be testing prolactin as well. Progesterone can be tested either in urine every few days, right, with the at-home urinary hormones test, or it can be tested as well 7 days after ovulation to see if it is high enough. So, because again, progesterone only comes after ovulation. We should be testing our thyroid function, so our TSH, T3, T4, and thyroid antibodies if you're trying to conceive. So that's anti-TPO and anti-TG. We should be testing our insulin. In my preference, I'm testing insulin fasting and fasting glucose. You drink the god-awful drink, and then half an hour and 1 hour and 2 hours later, we're testing your insulin and your glucose again. So we're looking at how your body responds to a sugar load, which will then help me to customize what type of dietary interventions we need. We should be testing our inflammatory markers. So at the very minimum, ESR and CRP. But we also do a variety of other immune tests at Advanced Women's Health. We should be testing our average glucose, so HbA1c, vitamin D, iron, and ferritin. So that's at a very minimum the things that we need to be looked at. But fundamentally, we have so much more to get into with endometriosis, the immune system, implantation, structure, sperm, like all of these things. But what we need to remember is that when you get all these labs done, if there's abnormalities, you deserve a team that understands how all of these hormones dance together and how you need to be supported to be able to fully understand and have really what we call informed consent. You know all your options, whether that is, again, advanced procedures like PRP and some of these other kind of surgical interventions that are happening, whether that is we're just working on the immune environment, getting your nutrients up to snuff, supporting fibrosis in the ovaries, supporting blood flow to the ovaries. Like, is that what's important? Whether we are supporting the brain communication to the ovaries, whether we're reducing bacterial load in the body, viral load. But what we need to know is that yes, ovulation is a very energy intensive process. It's a process that is months in the making, as we saw here with all these follicles developing. We know that there are so many factors that are involved. We went through just the surface of these things today. And we know that regular periods do not mean that you are ovulating. So if you're trying to conceive, thinking about trying to conceive, want to access some of these tests, then I highly recommend you book in with our team. Again, you can reach out to anyone at info@advancedwomenshealth.ca, send us a message. We're happy to help pair you with the best fit practitioner either in your region or, again, we can support many people virtually right now in Ontario and BC. That will continue to expand. So what I want you to understand is even if you left this episode and you felt really overwhelmed by the amount of information, you need to know that this is like just the bare minimum information that's available. So you can get an answer. Unknown, undiagnosed infertility, fears about unknown and undiagnosed infertility, they're a piece. But most of the time, as we'll talk about in the future, unknown, undiagnosed is immunological. It just means the investigations have not gone deep enough. And so I want you to rest assured that there are people here who can help you, who can get you some kind of answer, or at least get you a deeper investigation. So I hope this intro to ovulation and AMH and AFC was helpful. And I really just hope that you can take this and run with it and get the answers that you deserve. So next time we will dive into the immune environment, endo, and so much more. Thank you so much for listening. I hope that you had as much fun as we did. And if you loved today's episode, share it with a friend and leave us a review. That is how we spread this message, and that is how we are going to revolutionize healthcare in Canada for women. Have a beautiful day and be well.